The endocrine system is a collection of glands that produce hormones which regulate metabolism, growth and development, tissue function, sexual function, reproduction, sleep, and mood. The endocrine glands form a communication network linking all body systems. Hormones for these glands control and regulate metabolic processes such as energy production, fluid and electrolyte balance, and response to stress. This system is closely linked with the nervous system. In particular, the hypothalamus and pituitary gland play a major role in hormonal regulation. The hypothalamus manufactures and secretes several releasing or inhibiting hormones that are conveyed to the pituitary. The pituitary responds to these hormones by increasing or decreasing hormone secretion, thus regulating circulating hormone levels. This system is designed as a feedback control mechanism. Regulation of hormone secretion, stimulate or inhibit hormone synthesis. Positive feedback stimulates the release of a hormone when serum hormone levels are low, such as oxytocin in childbirth. Negative feedback inhibits the release of hormones when serum hormone levels are high, or the rising hormone level turns off the initiating change that triggered the release of the hormone. In examples when serum calcium fails, the parathyroid hormone secretion is increased. Remember, the parathyroid hormone stimulates the release of calcium. This same feedback system controls the secretion and inhibition of other hormones outside the hypothalamic pituitary control. These are a list of disease processes that we will be covering under this system. This is an example of the positive and negative feedback system as it relates to blood sugar controls. As blood sugar levels rise, the beta cells of the pancreas are stimulated to release insulin into the blood. The liver will take up glucose and store it as glycogen, and the body cells will take up more glucose. So, when blood glucose levels will decline to a set point and the stimulus for insulin release will diminish. When blood sugar levels decline, the alpha cells of the pancreas are stimulated to glucagon into the blood. The liver will now break down the glucagon and release glucose to the blood. Now, the blood glucose level will rise to a set point, and the stimulus for glucagon release will decline. Controlled glycemic levels is an important priority for all patients, and especially those who are critically ill. Target glucose levels may be somewhat different for medical as opposed to surgical patients. The goal in very ill surgical patients is intensive insulin therapy. It's tight control. It is aimed at maintaining a steady state of eugoglycemic levels. Medical patients have a broader recommended range for serum glucose levels. The American Diabetes Association recommends that glucose levels be controlled as close to 110 milligrams per deciliter as possible, and that levels should always be under 180 milligrams per deciliter. Management of hyperglycemia is attained through the use of protocols. These nurse-implemented protocols include frequent glucose monitoring and insulin dosage adjustments based on those levels. Frequent blood sugar monitoring is intended to ensure the appropriate insulin dosage and to minimize the incidence of hypoglycemia. Hypoglycemia is defined as a decrease in the plasma glucose level to less than 70 milligrams per deciliter. It is often referred to as insulin shock or insulin reaction. In this case, glucose production falls behind glucose consumption, resulting in a change in the level of consciousness. In addition, there is a rise in counter-regulatory hormones, those that work to increase blood glucose levels. It is a defense against hypoglycemia. Glucagon, epinephrine, cortisol, and growth hormones. Those listed here are at the highest risk level for experiencing hypoglycemic states. The pathophysiological mechanisms associated with acute hypoglycemia are reviewed in this figure. Patients receiving insulin therapy need to be closely monitored for hypoglycemia. This is especially true when the body's requirements are less than the insulin dose, or when injection sites are rotated from an area of diminished capacity to one with unimpaired absorption. Other causes of hypoglycemia in hospitalized clients is insufficient caloric consumption because of missed or delayed meals, decreased intake due to nausea, vomiting, anorexia, and interrupted tube feedings, or TPN, and patients with renal or liver dysfunction who require ongoing assessment. Also, think about patients that are like post-surgical patients that aren't eating solid foods. So in our post-op patients, they can develop confusion and shakiness. When serum glucose decreases rapidly, there is an activation of the sympathetic nervous system. Remember, the sympathetic nervous system inhibits insulin secretion. It is mediated by epinephrine release from the adrenal medulla. The compensatory fight or flight mechanism results in symptoms such as tachycardia, palpitations, tremors, cool, clammy skin, diaphoresis, hunger, pallor, and dilated pupils. Remember, if your patient is cold and clammy, they need candy, such as sugar. Glucose levels that diminish over an extended time frame result in symptoms related to an inadequate glucose supply to neural tissues. This produces symptoms such as restlessness, difficulty in thinking and speaking, visual disturbances, and paresthesias. These patients may have profound changes in level of consciousness, convulsions, or both. The confirming lab test for hypoglycemia is a serum glucose. In patients with a known history of diabetes mellitus, a thorough history of past episodes of hypoglycemia, including signs and symptoms previously experienced, must be obtained. Here is a slide of hypoglycemia. I think it'll help you if you see how it is spelled out as tired for tachycardia, irritability, restless, excessive hunger, and diaphoresis and depression. After a hypoglycemic state has been confirmed, carbohydrates must be administered. A mild blood sugar less than 70 milligrams per deciliter is considered mild. Moderate is a blood sugar less than 55 milligrams per deciliter, and severe hypoglycemic is a blood sugar less than 40 milligrams per deciliter. These are categories identified for determination of the appropriate route of administration. Level of consciousness and ability to swallow without risk for aspiration will assist in determination of the route. Common foods selected should contain a minimum of 15 grams of carbohydrates. So a lot of times we will give our patients like some graham crackers and peanut butter. Also, glucose levels must be reassessed in 15 to 20 minutes. If the levels remain below 70, the treatment should be repeated. Ongoing assessment of vital signs and EKG monitoring during the acute phase is also a priority. We also would repeat treatment if our patient's blood glucose level dropped below 70 milligrams per deciliter. Insulin should be stopped temporarily. Insulin pumps must be suspended. Neurological assessments are done to detect any changes in cerebral function related to hypoglycemia. Baseline neurological status, including mental status, cranial nerve function, sensory and motor function, and deep tendon reflexes are appropriate to obtain. Assessments for seizure risk is also carried out. Seizure precautions must be instituted, so as the nurse we may pad the side rails, administer oxygen, maintain oral airway, and removal of any harmful objects. Patients and families may need to be instructed on the causes, symptoms, treatment, and prevention of hypoglycemia. Principles regarding diet, insulin or oral hypoglycemic agents, and exercise may need to be incorporated into these teaching modules. Home glucose monitoring practices may need to be identified and restructured. The basic underlying mechanism for both diabetic ketoacidosis and hyperosmolar hyperglycemic state, which is HHNS, non-ketonic syndrome, is a reduction in the net effective action of circulating insulin coupled with an elevation of counter-regulatory hormones. This hormonal mix leads to increased hepatic and renal glucose production, but it prevents utilization of glucose in the peripheral tissues. Both DKA and HHS are endocrine emergencies. DKA historically is related to those with type 1 diabetes, where HHS has always been associated with type 2's diabetes. More and more frequently though, however, both crises may be observed in the same patient. Glucose stays in the blood because there's no insulin. Insulin takes glucose into the cell. In DKA, there is no insulin, so the body can't use it, and it just builds up in the blood serum. The body then attempts to use glucagon, which is the storage of glucose in the liver, because the body is confused. It thinks the body is in a hypoglycemic state because the body cannot get access to the glucose to use for energy without insulin. The body needs fuel. The glucagon is released and turned into glycogen, also known as glycogenolysis, and then into glucose, which increases blood sugar even more. Then the body starts to break down fats because it thinks the liver isn't doing its job. Fat breakdown turns into ketones. Ketones then breaks down to acids. This buildup of acids in the body causes the blood pH to drop, leading to metabolic acidosis. The kidneys are affected as well. Due to the excessive amount of glucose present, the kidneys are not able to reabsorb glucose normally. This causes glucose to leak into the urine, causing osmotic diuresis, which is polyuria, and the excretion of sodium, potassium, chloride, which leads to electrolyte imbalances and dehydration. If left untreated, hypovolemia and shock will develop. Renal failure furthers this condition, and death can occur as a result. DKA signs and symptoms: dehydration, poor skin turgor. Your patient will have poor skin turgor. They're going to have dry mucous membranes. They're going to be hot and dry to the sugar high. They're going to have tachycardia, orthostatic hypotension, because they have peripheral neuropathy that can affect nerves of the autonomic nervous system, and as a result develops high dehydration. They're going to be lethargic, confused. They could have abdominal pain and vomiting. They could develop Kussmaul's respirations, which is rapid, deep breathing. This is the body's attempt to reverse metabolic acidosis by breathing off excess carbon dioxide. It's the respiratory compensation. They may have fruity breath, acetone sweet odor. Their labs could be as follows: glucose, which is greater than 250, an arterial blood pH, which would be less than 7.30, serum bicarb less than 15, and ketones in the urine or blood. DKA occurrences and causes occurs in type 1 diabetes, but may also occur in type 2 diabetes during times of severe stress, illness, or when the pancreas is no longer able to meet the demands for insulin production. DKA develops over a very short period of time and has a statistical recurrence rate greater in young females. The most common triggers for DKA are infections, inadequate insulin therapy, and severe stress states. Many patients may have DKA as an initial indication of previously undiagnosed diabetes type 1. There are certain drugs that have been associated with the development of DKA, such as alcohol and drug abuse, corticosteroids, and some diuretics. This condition may also occur in patients with known diabetes mellitus who do not administer enough insulin or have increased insulin requirements. Also, not eating or skipping meals. Because fluid balance can be potentially life-threatening, the goal of therapy is hydration and electrolyte replacement. Electrolyte deficits include sodium chloride, bicarbonate, potassium, phosphate, magnesium, and nitrogen. An initial bolus of 0.9% sodium chloride or 0.45 sodium chloride is given to restore urine output to 30 to 60 milliliters an hour and raise blood pressure. Infusion is given at 1 liter per hour until blood pressure is stabilized and output is 30 to 60 milliliters an hour. Once blood glucose reaches 250, D5 is added to prevent hypoglycemia. So 5% dextrose is added once the blood sugar reaches 250 to prevent hypoglycemia. Potassium levels must be attained prior to starting an insulin drip. Remember, insulin pushes potassium into the cells. If the patient is hypokalemic, insulin would further decrease the potassium levels. Also, even if potassium levels are normal prior to treatment, potassium levels can drop quickly once treatment is started due to insulin driving potassium into the cell. Early potassium replacement is essential because hypokalemia is a significant cause of unavoidable death during treatment of DKA. So just remember, potassium must be at least 3.5 before insulin can be given. Incorrect fluid replacement can lead to a sudden decrease in serum sodium that can lead to cerebral edema. So it is essential to monitor fluid volume overload, especially in renal and cardiac patients. Insulin therapy is used to correct hyperglycemia and hyperketonemia. Insulin therapy is held until fluid resuscitation and serum potassium is greater than 3.5. It is important the blood glucose not be lowered too quickly. Doing so could lead to cerebral edema. Blood glucose should be reduced at a rate of 36 to 54 milligrams per deciliter per hour. Administer sodium bicarb to help correct the acid-base balance. This should only be done if the pH is less than 7. Nursing interventions should include the following. Monitor the patient's vital signs, their heart rate and rhythm, oxygen saturations, their I's and O's, so their intake and output, their potassium levels, and serum blood glucose. As a nurse, you're going to be assessing for the breath sounds for possible fluid volume overload. You're going to give fluids and administer sodium bicarb if pH is less than 7. So I like this diagram here. Just remember on this slide, or always remember, the Kushmal rapid deep breaths. It's basically to help blow off the CO2 for these patients. HHS is more common in type 2 diabetics. These patients are able to produce enough insulin to prevent DKA, but not enough to prevent severe hyperglycemia, osmotic diuresis, and fluid depletion. HHS is usually precipitated by inadequate insulin secretion or action. Occasionally, these patients report no history of diabetes mellitus. Most patients are elderly, so over 60, with diminished compensatory mechanisms that reduce their abilities to maintain homeostasis in hyperosmolar states. It is believed that often a major illness mediated through glucose overproduction resulting from the stress response may contribute to the development of HHS. Other causes include infections of the urinary tract, pneumonia, sepsis, acute illness, or newly diagnosed diabetes mellitus type 2. High caloric parental or internal feedings that exceed the patient's abilities to metabolize glucose have induced HHS. This slide here just gives you the pathophysiology of DKA and HHS. So the main difference of DKA and HHS is that the patient with HHS usually has enough insulin to prevent ketoacidosis from occurring. The patho of DKA is related to an insulin deficiency, resulting in cellular dehydration and volume depletion, acidosis, and protein catabolism. It is usually seen in those with a history of type 1 diabetes, but may be seen in type 2 diabetics who are under severe stress. Symptoms of hyperglycemia exist before admission, but the onset is very rapid. Hyperosmolar hyperglycemic state is also the result of an insulin deficiency that causes dehydration and hyperosmolality. HHS is usually seen in those with a history of type 2 diabetics. Symptoms of HHS are also in existence prior to admission, but usually have fewer symptoms, so blood glucose levels get very high. This condition will occur frequently in the elderly with pre-existing renal and cardiovascular disease. This condition develops slowly over time. The presenting symptoms of DKA and HHS are similar. The signs of DKA and HHS are related to the degree of dehydration present and the existing electrolyte imbalances. The osmotic diuresis results in signs of thirst, increased urinary output, and dehydration. Their skin will be flushed and dry. Mucous members will also be dry. A decrease in skin turgor exists. Tachycardia and hypotension are present in both conditions. In DKA, the excessive production and decreased metabolism of ketone bodies results in ketonuria and loss of bicarb, leading to metabolic acidosis. Respirations in DKA are described as couchements, which is an increase in rate and depth, in an attempt to compensate for the metabolic acidosis by eliminating CO2. Breath odor is noted as fruity from the fat metabolism that occurs in DKA. In HHS, the excessively high blood glucose levels leads to an increase in serum osmolality, which leads to more serious neurological manifestations such as somnolence, coma, seizures, hemiparesis, and aphasia. Since these are similar to stroke, establishing a blood glucose is essential to determine proper treatment. So just remember, HHS is often slow and shows signs and symptoms of a stroke or neurological manifestations. Numerous diagnostic studies are used to evaluate for DKA and HHS to rule out other diseases and to detect complications. In addition, cultures and testing are performed to determine any precipitating factors such as infection and myocardial infarction. In DKA, initial ABGs may indicate metabolic acidosis, which would be a low pH and low bicarbonate. The partial pressure of arterial CO2 may also be reflecting the respiratory system compensatory mechanism. Severe acidosis is associated with cardiovascular collapse and death. In HHS, the lab results are similar to those in DKA, but with 4 major differences. 1, the serum glucose concentration is significantly more elevated, so usually greater than 600. The plasma osmolality is higher. The acidosis is not present or very mild compared with DKA, and ketosis is usually absent or mild. Azotemia is high levels of nitrogen-containing compounds in the blood, so urea, creatinine. Interventions include respiratory support, fluid replacement, insulin therapy, electrolyte management, treatment of acidosis, and education. Airway and breathing may be supported through the use of oral airways and oxygen therapy. In more severe cases, intubation and ventilation may be indicated. NG tubes are considered to reduce the risk of vomiting and subsequent aspiration. Immediate rehydration must be accomplished. Monitoring for signs and symptoms of hypovolemic shock is a priority. Vital signs and neurosigns must be assessed and recorded frequently. Hemodynamic parameters may be indicated for more unstable patients. Right atrial pressure or pulmonary artery pressure monitoring may be instituted to evaluate fluid requirements and to monitor the patient's response to treatment. Normal saline or 0.9% NS is the fluid of choice for initial fluid replacement because it best replaces extracellular fluid volume deficits. So an initial bolus of 1,000 milliliters, then 10 to 20 milliliters per kilogram in the first hour. After the blood pressure and serum sodium normalizes, the fluid is changed to a hypotonic solution such as 0.45 normal saline at slower rates. Insulin therapy is the definitive therapy for DKA and HHS. Before starting, again, fluid replacement must be underway and serum potassium greater than 3.5. Most commonly, hyperglycemic crises are treated with IV insulin infusions because absorption is more predictable. An initial IV bolus of insulin of 0.1 to 0.15 units per kg of regular insulin is administered, followed by a continuous infusion of 0.1 units per kilogram per hour. Potassium, phosphate, chloride, and magnesium replacement may be required, especially during insulin administration. Osmotic diuresis in DKA and HHS results in total body potassium depletion. The potassium deficit may be greater in HHS. Replacement and monitoring should begin after the first liter of IV fluid has been administered. The potassium is greater than 3, and the patient is excreting urine. Integrity of the IV site must be monitored to prevent extravasation. EKG monitoring for cardiac dysrhythmias is also required. Acidosis is the hallmark feature of DKA. However, studies have indicated that treatment with sodium bicarb is not beneficial unless the serum pH is less than 7. When it is administered, it is added to 5% dextrose in water, or D5W, or sterile water and replaced slowly. A primary intervention to prevent DKA is patient education. So as nurses, we're managing blood glucose levels with their diet, exercise, and medication. Those are all priorities. Monitoring their hemoglobin A1C 2 to 3 times a year is reflective of the patient's long-term control of blood glucose. Here's another chart that you can also look at, DKA versus HHS. All right, now we're going to move into disorders of the pituitary gland. The primary function of ADH, or the antidiuretic hormone, is the regulation of water balance and serum osmolality. ADH is also known as arginine vasopressin. AVP is a potent vasoconstrictor. It is produced in the supraoptic nuclei and paraventricular nuclei of the hypothalamus. Osmoreceptors in the hypothalamus respond to changes in extracellular osmolality. Stretch receptors in the left atrium respond to changes in circulating volume and blood pressure. Once ADH is released, it acts on the renal distal and collecting tubules to cause water reabsorption. In high concentrations, ADH also acts on smooth muscles of the arterioles to produce vasoconstrictions. Under normal conditions, ADH is released in response to the following: increased serum osmolality, which is the primary stimulus, elevated serum sodium levels, a decrease in blood volume of greater than 10%, a 5 to 10% drop in blood pressure, stressors such as trauma, hypoxia, pain, and anxiety and nausea and vomiting, narcotics, barbiturates, anesthetics, and chemotherapeutic agents. ADH is inhibited by the decrease in plasma osmolality, increase in fluid volume, and alcohol, ETOH. This chart here summarizes the physiology of ADH release. Two common disturbances of ADH are DI, which is diabetes insipidus, and SIADH, which is syndrome of inappropriate antidiuretic hormone. DI is associated with a decrease in production or secretion of ADH. This results in fluid and electrolyte imbalances due to increased urinary output and increased plasma osmolality. DI is classified as neurogenic and nephrogenic. The primary cause of neurogenic DI is traumatic injury to the posterior pituitary or hypothalamus as a result of head injury or surgery, resulting in a decrease of ADH synthesis, transport, or release. This is the most common form. A form of transient DI may occur after pituitary surgery or trauma resulting from manipulation of the pituitary stalk or cerebral edema. Permanent DI occurs when more than 80% of the pituitary stalk is destroyed. Nephrogenic DI may occur in genetically predisposed persons. It is a condition where there is adequate ADH, but there is a decreased response to ADH in the kidneys. Regardless of the cause, the effect is impaired renal conservation of water resulting in polyuria, which is greater than 3 liters in 24 hours. So as long as the thirst center remains undamaged and the individual is able to respond to this thirst, fluid volume can be maintained. If the client is not able to react, severe dehydration will result if fluid losses are not replaced. Neurogenic DI is the most common type you will see. In this form, absent or diminished release of circulating levels of ADH from the posterior pituitary produce free water loss and causes serum osmolality and serum sodiums to elevate. The posterior pituitary is unable to respond by increasing ADH levels. Therefore, the kidneys are not stimulated to reabsorb water, and excessive water loss results. Neurogenic DI usually occurs suddenly with an abrupt onset of polyuria, as much as 5 to 40 liters in 40 hours. The onset of nephrogenic DI occurs over a period of time. The urine in both classifications will appear pale and dilute. If your client is conscious and the thirst mechanism has activated, you will observe polydipsia. If unconscious and water has not been replaced, signs of hypovolemia will develop, such as the following: hypotension, decreased skin turgor, dry mucous membranes, tachycardia, weight loss, and low right atrial and pulmonary artery occlusion pressures. Neurological signs and symptoms are seen with hypovolemia and hypernatremia, and these will include the following: confusion, neuromuscular excitability, hyperreflexia, seizures, or coma. A classic sign of neurogenic DI is a very low urine osmolality in combination with a significant elevated serum osmolality. Corresponding with the low urine osmolality is a decreased urine-specific gravity. Serum osmolality is elevated as a consequence of hypernatremia from the pure water loss that is occurring in the kidneys. The presence of hypokalemia or hypercalcemia suggests nephrogenic DI. Other values such as BUN and creatinine may be elevated as a result of hemoconcentration. A priority intervention is to monitor for signs and symptoms of hypovolemia and maintain electrolyte balance. Just remember with DI, they're dehydrated and dry. Vital signs must be recorded at least every hour along with urine output. Hemodynamic monitoring may be necessary to evaluate fluid requirements and to monitor client response to treatment. This is especially important in older adults who are more likely to have concurrent cardiovascular and renal disease. Accurate I's and O's along with daily weights are essential. Ongoing measurements of urine-specific gravity aids in evaluation of client response to treatment. Once medication therapy has begun, the urine should become more concentrated and the specific gravity should increase. Fluid replacement will be necessary in those individuals who are not able to drink enough water to avoid hypovolemia. Fluid must replace existing water losses and keep up with current losses. Correction of hypernatremia and replacement of free water is achieved by using hypotonic solutions of D5W, so 5% of dextrose in water. In case of circulatory failure, isotonic saline may be administered until hemodynamic stability occurs and vascular volume is restored. Frequent nausea and vomiting monitoring is required, as changes may be indicative of a change in fluid status, electrolyte states, or both. Hormone replacement with exogenous ADH preparation is necessary due to a decreased secretion of arginine vasopressin in neurogenic DI. These ADH preparations enable the kidneys to conserve water. Intravenous forms of the medication are generally more potent and are absorbed more effectively. The medication most commonly used is desmopressin, which is a form of vasopressin. Remember, vasopressin is an antidiuretic hormone. It helps reabsorb water in the body. It will help raise the blood pressure and putting water back into the body. So here's just a slide for you to look at for diabetes insipidus. All right, syndrome of inappropriate antidiuretic hormone, SIADH, is the inappropriate release of ADH, whether the plasma osmolality is low or high. It results from an abnormal production or secretion of ADH. A common cause of SIADH is the ectopic production of ADH by malignant disease. The malignant cells actually synthesize, store, and release ADH. In effect, this puts control of ADH outside the normal pituitary hypothalamus feedback loops. Non-malignant pulmonary conditions such as TB, pneumonia, lung abscess, and COPD can also produce SIADH. CNS disorders such as head injuries, infections, hemorrhages, surgery, and cerebral vascular accidents can produce SIADH. This problem is related to stimulation of the hypothalamic or pituitary system or both. There is an increasing concern regarding the widely prescribed usage of selective serotonin reuptake inhibitors on ADH levels and function. These medications are in the category of antipsychotic drugs, commonly used as antidepressants. The mechanisms involved include increasing the action of ADH, acting on the renal distal tubules to decrease free water excretion, and some familiar medication in this discussion are Celexa, Lexapro, Prozac, Paxil, and Zoloft. SIADH occurs when the body secretes excessive ADH unrelated to plasma osmolality. This occurs in light of a failure of the negative feedback mechanism that regulates the release and inhibition of ADH. The results are an inability to secrete a dilute urine, fluid retention, and dilutional hyponatremia. Cerebral salt wasting, which is CSW, is similar to SIADH, with the main difference being fluid status. CSW is a disorder of sodium and fluid balance that occurs in patients with a neurological insult. In both SIADH and CSW, serum sodium is decreased and urine sodium is elevated, but SIADH patients must have fluid withheld, whereas those experiencing CSW must have fluids replaced. ADH stimulation produces a clinical picture of water intoxication. The clinical signs and symptoms are primarily the result of water retention, hyponatremia, and hypoosmolality of the serum. The severity is related to the rate of onset and the severity of the hyponatremia. The central nervous system will present with symptoms of weakness, lethargy, mental confusion, difficulty concentrating, restlessness, headaches, seizures, and a coma as a result of the low sodium and serum osmolality. Increases in intracranial pressure as a result of cerebral edema are the outcomes of the low osmolality, causing water to shift into the brain cells. The GI tract will experience a decrease in motility due to the electrolyte imbalance, causing nausea, vomiting, anorexia, muscle cramps, and diminished bowel sounds. In relation to the CV system, patients may present with complaints of weight gain and elevated blood pressure. Pulmonary findings related to the fluid overload will display an increase in respiratory rate, dyspnea, adventitious lung sounds, and frothy pink sputum. Low urinary output with a high specific gravity urine, so it's very concentrated. Nursing interventions for SIADH are as follows: frequent vitals, strict monitoring of I's and O's, neurostatus and their level of consciousness, be alert for low urinary output and high specific gravity urine. Daily weights, be aware of sudden weight gain with no edema. Monitor heart and lung sounds for fluid volume overload, as they could be developing shortness of breath and edema. Also monitoring for a decline in serum sodium, which could be seizures, nausea, vomiting, muscle cramping, change in mental status. Management includes the following: 1,000 milliliters per day, so they're on a fluid restriction. Head of the bed should be up at least 10 degrees to enhance venous return to heart and increase left atrial filling pressure, which will help to reduce ADH release. Frequent oral hygiene to help with discomfort from thirst due to fluid restriction. Sodium less than 120 would require IV hypertonic saline solution. 3 to 5% may be administered, but must be done slowly to avoid increasing sodium too quickly. Lasix may be given, but only in serum sodium at least 125. If used, electrolyte replacements may be needed, such as potassium, calcium, and magnesium. If severe hyponatremia, their fluid restriction would be 500 milliliters per 24 hours. So with our SIADH, we're going to restrict fluid intake with these types of patients. This table compares the electrolytes and fluid findings associated with diabetes insipidus and syndrome of inappropriate antidiuretic hormone. So make sure you know your labs. The adrenal glands are located superior to each kidney and composed of the adrenal medulla, which is the inner layer of the adrenal gland, and the adrenal cortex, outer layer of the adrenal gland. The medulla secretes the catecholamines, which are epinephrine, norepinephrine, and dopamine. The cortex secretes adrenal cortex steroid hormones, which are glucocorticoids, mineralocorticoids, and androgens. Functions of catecholamines include increasing metabolic rate, increasing alertness, increasing insulin levels, and the fight or flight response. The functions of glucocorticoids include assisting the body's response to stress, suppression of inflammation, increasing serum glucose, and regulating metabolism of carbs, fats, and protein, improving the synthesis of proteins and the breakdown of protein and fatty acids. Mineralocorticoids assist with sodium and water retention and potassium excretion. Androgens and estrogens contribute to growth and development. In Addison's disease, the production of adrenocorticosteroids may decrease as a result of inadequate secretion of ACTH dysfunction of the hypothalamic pituitary control mechanism or direct dysfunction of adrenal gland tissue. Insufficiency of adrenocorticosteroid causes problems through the loss of aldosterone and cortisol action. Diminished action of cortisol affects gluconeogenesis, which is the making of glucose from proteins. And the resultant effects are hypoglycemia following the depletion of liver and muscle. Reductions in the secretion of aldosterone result in various electrolyte imbalance. In acute adrenal insufficiency or Addison crisis, the need for cortisol and aldosterone are greater than the available supply. So basically with Addison's, you need to add hormones. You need to add the cortisol and aldosterone. The onset is frequently linked to surgery, trauma, and severe infectious processes such as cancer, and occurs with a concurrent reduction in adrenal hormone output. Unless intervention is initiated promptly, sodium levels fall and potassium levels rise rapidly. More severe hypotension results from the blood volume deficit that occurs with the loss of aldosterone. Treatment is focused on hormonal replacement, which is consisting of normal saline or D5W with infusions of hydrocortisone and an H2 histamine blocker for ulcer prevention. Hyperkalemia management requires infusion of D5NS to shift potassium into the cells, potassium restrictions, INOs, and heart rate and rhythm monitoring. Hypoglycemia management consists of the administration of IV glucose with frequent monitoring of blood sugar levels. Addison's disease is classified as primary or secondary. Primary disease is more frequently considered idiopathic. However, Secondary disease is more commonly noted in those who have undergone sudden cessation of long-term high-dose glucocorticoid therapy. This suppresses production of glucocorticoids through negative feedback by causing atrophy of the adrenal cortex. Glucocorticoid medication must be withdrawn gradually to allow for pituitary production of ACTH and activation of adrenal cells to produce cortisol. All right, so this is just a clinical presentation and slide of Addison's disease. Just keep note of this. These patients are going to display weight loss, hypoglycemia, postural hypotension. They're tired and weak, increased pigmentation. An accurate history is important to receive from individuals suspected of presenting in either Addisonian crisis or for evaluation for Addison's disease. If confusion is present, the family or support network might be available as an alternative source of information. As a nurse, you should be asking about factors that may be responsible for decreased adrenal function. Look for changes that may have occurred in activity levels. Are they lethargic? Or they have fatigue or muscle weakness? Find out about their salt intake. Salt craving often occurs with hypofunction. As GI symptomology frequently is present, find out about recent weight loss. Women may experience menstrual changes and men impotence. Physical assessment includes assessing for key features related to the following: neuromuscular function, GI manifestations, integumentary alterations, and cardiovascular symptomology. Nursing interventions are aimed at promotion of fluid balance, monitoring of fluid deficit, and prevention of hypoglycemia. Weigh the patient daily and record accurate I's and O's. Assess vital signs every 1 to 4 hours, depending on the presence of dysrhythmias and postural hypotension. Assess lab values to identify hemoconcentration. Fluid losses should be replaced with an infusion of D5NS until signs and symptoms of the hypovolemic state stabilize. This not only reverses the volume deficit, but it also provides glucose to minimize the hypoglycemia. The patient may need as much as 5 liters of fluid in the first 12 to 24 hours to maintain an adequate blood pressure and urine output and to replace the fluid deficit. Hyperkalemia frequently responds to volume expansion and glucocorticoid replacement and may require no further treatment. In fact, it's impossible that the client may even become hypokalemic during therapy and may require potassium replacement. Acidosis may self-correct following volume expansion and glucocorticoid replacement. So, if your patient's pH is less than 7.1 or if bicarb is less than 10, sodium bicarb may be required. Cortisol and aldosterone deficiencies are corrected by replacement therapy. Hydrocortisone corrects glucocorticoid deficiency. So Solu-Cortef is the drug of choice because it contains glucocorticoids and mineralocorticoids, which is also known as prednisone. Florinef is a mineralocorticoid which may be necessary to maintain electrolyte balance, especially with sodium and potassium. Cushing's syndrome is a cluster of physical abnormalities caused when the adrenal glands secrete a disproportionate amount of corticosteroids, particularly glucocorticoids. This excessive secretory process may result from a problem in the adrenal cortex, the anterior pituitary gland, or within the hypothalamus. The presence of excess glucocorticoids, regardless of the cause, affects metabolism and all body systems to some degree. Nitrogen, carbohydrates, and mineral metabolism are all altered. An increase in total body fat results from slow turnover of plasma fatty acids. This fat is redistributed to produce the typical body pattern of truncal obesity, buffalo hump, and moon face. As tissue protein breakdown and urine nitrogen excretion increases, a decrease in muscle mass, thinning skin, and fragile capillaries become evident. Individuals also experience marked decreases in overall bone density. Cushing's syndrome is classified in one of three categories. The primary disease usually results from a tumor which stimulates an increased production of cortisol. Secondary disease results in an increased release of ACTH or from an ectopic disorder, which could be tumors of the lung or pancreas that produces ACTH. Lattertronic Cushing's is the most common cause and occurs as a consequence of long-term glucocorticoid therapy causing excessive cortisol levels. Regardless of the cause, the patient with hypercortisolism has many changes because of the widespread effect of excessive cortisol levels. So as a nurse, you're going to want to observe the client's general appearance. Upon examination, you may discover integumentary changes resulting from blood vessel fragility. Acne may be present and a fine coating of hair over the face and body. Cardiovascular changes occur as a result of altered water and mineral metabolism. Both sodium and water are reabsorbed and retained, leading to hypervolemia and edema formation. The blood pressure and heart rate are usually elevated. Musculoskeletal changes occur as a result of nitrogen depletion and mineral loss. So they have a decrease in muscle mass and usually noted in the arms and legs. Pathological fractures are a risk for these individuals. Glucose metabolism is profoundly affected by hypercorticolism. Fasting blood glucose are very high because the liver is stimulated to convert more glycogen to glucose, and the insulin receptors are less sensitive, so that blood glucose does not move as easily into the tissue. From a psychological standpoint, the clients may simply report that they just don't feel like themselves. The family members may confirm as well. Lab tests may include urine cortisol levels, which could be high regardless of the disease origin. ACTH will vary depending on the underlying cause. Various types of imaging are useful to identify lesions of the adrenal or pituitary glands, lung, GI tract, or pancreas. Patient safety includes preventing fluid overload from becoming worse, leading to pulmonary edema and heart failure. The older adult with coexisting cardiac, renal, pulmonary, or hepatic problems is at greater risk for adverse outcomes related to fluid overload. Drug therapy involves the use of medications that interfere with ACTH production or adrenal hormone synthesis, or medications that are considered to be adrenal cytotoxic agents, which are used for inoperable adrenal tumors causing hypercortisolism. Nutritional therapy will include restriction of fluid and sodium intake. Intake, output, and frequent weights provide information regarding the efficacy of this therapy. Radiation therapy is often used to treat hypercortisolism caused by pituitary adenomas. However, this is not always effective and may destroy significant amounts of healthy tissue. Surgical management includes removal of the pituitary glands, or transfrontal craniotomy approach, or a partial or complete adrenalectomy, which is the removal of the adrenal tumor from the adrenal gland. Here is the lab profile for adrenal gland assessment. Again, make sure you know your labs. Pheochromocytoma is a rare catecholamine-producing tumor that occurs in the adrenal medulla. They are usually a single lesion on one adrenal gland, but can be bilateral or in the abdomen. Only 10% are malignant. The tumors produce, store, and release epinephrine and norepinephrine. Excessive release of these substances stimulate adrenal receptors and can have wide-range adverse effects, mimicking the actions of the sympathetic division of the autonomic nervous system. Assessment involves identification of reported episodes of hypertension with concurrent severe headaches, palpitations, diaphoresis, flushing, and apprehension. Chest pain and GI symptoms such as abdominal pain, nausea, and vomiting may be reported. Certain medications such as glucagon or tricyclic antidepressants or food items such as aged cheese, red wine may induce a hypertensive crisis. Heat intolerance, weight loss, and tremors have also been reported. The most common diagnostic test is a 24-hour urine to detect catecholamines. MRI or CT scans can locate tumors in the adrenal gland. Surgical removal of one or both adrenal glands is the main treatment. It is important to remember not to palpate the abdomen because this action could cause a sudden release of catecholamines and severe hypertension. Anesthetic agents and manipulation of the tumor during surgery also have the potential to cause the same chemical release. Post-operatively, blood pressure must be monitored. Hypotension is a risk from the sudden decrease in catecholamine levels.